young medical doctor that was awarded with our ISE ECG award. So my name is Tom Ribeiro. This is an ISE session, the ISE webinar, in which we will use the first few minutes to give the award to the winner of the ISE ECG award for the year of 2021. I would like to stress that this award is received the names of Professor Antonio Baez de Luna, who is based in Barcelona, who is one of the most important persons in electrocardiology nowadays. He had a great and has a great scientific contribution for ECG, but very important for this award that Baez de Luna, Antoni, has a very important role in teaching cardiology and training persons in reading ECG and making ECG a method that is available everywhere to all medical doctors, to all persons involved. So we believe that this prize, this award, gives the sense that ECG is now a method of more than a century, that was discovered more than a century ago. It's more and more important every day, and that we need young researchers working with ECG, trying to get the best of this method, and to have Baez de Luna as the mentor of all this movement is very important for us. We have this time 3 persons involved in this selection, and the Professor Baez de Luna, Professor Rob McLeod from the United States, and Professor Bulun Goranek, who is the current president of our society, and the awardee, the person who received the prize, is Dr. Pavel Matuzik, and we are very, very pleased that he was selected. And I will give the word to Pavel for a few words, and then I will ask Professor Baez de Luna to close this part of the session very, very briefly. Pavel, congratulations, and please give your few words about this.
Okay, thank you. Thank you very much, Dr. Tom Ribeiro, for this presentation. I am very pleased that the award that received my name will be given here to a distinguished fellow that has been a very good cardiologist in the last years. And it is for me a great honor that we are here with all of you giving this commemoration. So thank you very much for inviting me to this celebration, and my congratulations to Dr. Masudik for the award that he will receive in a few seconds. Thank you very much to all of you.
Thank you, Professor Baez de Luna.
I want to stress the importance of the training in electrophysiology just in the days that we are living. It is a very easy exploration that gives to us a lot of information, and it is a cheap one, and we have been demonstrating that may give great information about the possible associations of risk factors in the future. So I want to advise to young cardiologists that start to give research and investigation in electrophysiology, and sponsored by the Society of Electrocardiology that is giving this award. Thank you very much to the Society, to Tom Ribeiro. Thank you.
Thank you, Professor Baez. Dr. Pavel, you are the person now.
Dear professors, dear members of the International Society of Electrocardiology, dear colleagues, thank you very much. I am very honored to receive this award. I would like to thank my co-workers who participated in the research papers and projects which resulted in the recognized publications. I hope to further cooperate with members of the International Society of Electrocardiology and its young community, especially in the field of atrial fibrillation, sudden cardiac death risk stratification, and rare arrhythmogenic disorders research. I think that due to close cooperation, both electrocardiology science and our patients may benefit the most. Thank you once again for this very important award. It's a great honor for me.
Fantastic, Pavel. We wait you in Belo Horizonte next year. Yes, Bulent, 2022. Okay.
I hope so to see you. That would be great.
Okay, Bulent, the ball is back to you.
Yeah, thank you, Tom. Thank you, Anthony, and congratulations again, Pavel. Now we will continue the second part with the webinar. I am passing the microphone to Gary and Kamalan, please.
Yeah, so I'll introduce Kira then. So this Kira Lignick is a medical student at Queen's University from Canada. So she'll be presenting today to the audience about the roles of snakebite and in mediating the ECG changes. So yeah, please, Kira, be nice to hear from you.
Hello, everyone. So I'm just going to get quickly set up here. So are you seeing my full screen or the presenter view?
Yes, we can.
Perfect. Yeah.
Full screen? Perfect. All right. So my name's Kira, as Gary said. I am a second year, just finished my second year medical student at Queen's and a first year master's student in translational medicine. And today I'm going to chat briefly with all of you about snakebite envenomation and the ECG. So we really care about snakebite envenomation because it affects so many individuals globally. There are individuals even in North America who are affected every year, even though we don't have that higher prevalence of venomous snakes. And we're actually seeing in countries now that there's an increased trade of tropical snakes sold as pets, and we're seeing complicated envenomation cases that people aren't prepared to treat because they have no training in that area. So there are about 2.7 million snakebite envenomation cases annually, leading to about 140,000 deaths. And this is actually thought to be an underestimate because so many of these occur in tropical and rural areas where there's limited access to data infrastructure and reporting cases. The general pathophysiology is that zootoxins are contained in snake venom, which modify physiological processes. And it becomes more complicated because not only does snake venom vary quite a bit between different species, but also within the same species in different regions. Some of the main cardiotoxic compounds that we found in snake venom are natriuretic peptides, bradykinin potentiating peptides, VEGF, and phospholipase A2. And interestingly, as an aside, the Brazilian pit viper venom contains a bradykinin potentiating peptide, which inhibits angiotensin converting enzyme and was actually used to develop the first ACE inhibitor, Catepril. So today I'm going to focus predominantly on cardiovascular consequences of snake envenomation. And then within that, we're going to focus on rhythm abnormalities. So approximately 50% of snake envenomation cases result in systemic consequences and hospitalization. Now, there's very limited data on the systemic complications of snakebite just because of their regional distribution, but it is estimated that approximately 70% of cases have some sort of cardiovascular involvement. And within those, 40% of them present with severe ECG changes. And today I'm going to be talking about some of the more common ones. So ST elevation, ventricular tachycardia, and bundle branch block. And then also some of the more deadly, so the ventricular fibrillation. And I thought the best way to do this, because there are no really larger systematic reviews in the literature, only really case studies and case series, is to actually take you all through a few cases, how they were managed, and what the ECG changes were. So first, I'm going to chat a bit about ventricular tachycardia. So I present to you a case of a 46-year-old man who was envenomed by a Russell's viper in India. He presented with rhabdomyolysis, renal failure, and then progressed to monomorphic ventricular tachycardia and was treated with cardioversion, a multi-day course of amiodarone and antivenom. So something I'm going to be saying throughout this presentation, and that's the most important, is that when we do have cases of snake envenomation, that we do early antivenom, we do the earliest antivenom possible, as it really improves outcomes. And because antivenom is actually released from the tissue quite slowly around the bite site, if you don't continuously administer antivenom, the patient will not improve. So here they actually needed the amiodarone for a few days, antivenom for a few days, and the only actual consequence of discharge was a prolonged QT interval. And although the patient was lost to follow-up, it was estimated they likely had no severe cardiovascular events associated afterwards. Something else I'll be coming back to is just this figure. So this is just from a paper we recently published on cardiovascular implications of snakebite envenomation. And it highlights some of the pathophysiological mechanisms introduced in the literature. Now, we know very little about the actual molecular involvement and interactions between snake venom, cardiotoxicity, and cardiovascular implications. Although there is some more research done in this area on more of the granular information that Jeremy will be discussing in scorpion venom, where there are actually some similar effects. But generally, in this case, the authors talked a little bit about direct damage to cardiac cell membranes. So it's believed that snake venom modifies the electrophysiological properties of the cardiac cell membrane and can have profound effects on impulse generation and conduction throughout the heart. Now, we don't know the exact mechanism of this, but in some mouse studies, it's been shown that these snake cardiotoxins do bind to the myocardium and cardiac cell membranes. So another one of the more important implications is ST elevation. This one I'll spend a bit more time on because there are three kind of main ways that we see this presenting in cases in the literature. The first is a case where we have a 73-year-old male who presents with the classic clinical picture of AMI, so acute myocardial infarction, hypotensive, lethargic, diaphoretic, retrosternal chest pain, and also has underlying cardiovascular disease, which is the important note in this case. So this individual presents with ST segment elevation, and then upon angiogram had 80% mid-vessel stenosis of the circumflex artery, and additionally had the thrombus formation. So this person was treated with antivenom and a stent. It's important to note that we want to not be too quick to anticoagulate individuals or administer thrombolytics to individuals who have experienced snakebite envenomation, because thrombocytopenia as well as coagulopathy are quite common in this population and increased risk of bleeding events, which might cause complications if thrombolytic agents are given. So this individual was just had a stent placed and was given antivenom, had some T-wave inversion still at discharge, and then at repeat follow-up over 3 months, had no other cardiovascular consequences. This case introduces that we can have that underlying cardiovascular disease, but also that snake envenomation can cause toxin-induced coronary spasm. So what's really important here is to give an initial bolus of antivenom, and as well as doing continued monitoring of coagulation studies. There's been some talk in the literature about steering away from using transfusion products like fresh frozen plasma, as well as administering platelets, just because they have such a short-lived effect and might actually increase the volume of distribution and decrease the efficacy of the antivenom, which is actually cleared quite quickly renally. Although I think in emergent cases, this has been used successfully in certain individuals experiencing coagulopathy. So here we have another case of ST elevation, but this one varies in that there was no underlying cardiovascular disease. And then there was seen an inferior wall infarction as well as an atrial fibrillation. Now this individual was cardioverted, but then only given antivenom to manage cardiotoxicity, and 90 minutes later had just T-wave inversion, and then on follow-up, no repeated cardiovascular events. So this is an interesting case because we see that we had those ECG changes that were transient, and there were no residual ischemic changes. And this really speaks to that when a patient doesn't have underlying cardiovascular disease, this truly might just be an venom-induced coronary spasm causing that ST elevation. Now, this individual did not receive an angiogram because they also had quite severe neurological implications of the venom, but they did have an echo, and the echo was completely normal. And then finally, in terms of ST elevation, we have a 28-year-old individual with no risk factors of cardiovascular disease, presented initially hypotensive and was given noradrenaline, and then progressed to acute ST elevation in inferior leads, and then actually developed torsades point rhythm and was given IV magnesium. This individual demonstrated on echo mild hypokinesia of the anterior wall and showed a LAD thrombus with normal coronary arteries So had no atherosclerosis, underlying disease, but still had a large thrombus, and that was just cleared with an exciser and medically. And then this patient was discharged on aspirin and had no repeat events. So here this kind of introduces also the importance of not only do we have toxin-induced coronary spasm, but then also risk of having thrombi. So we know about, of course, disseminated intravascular coagulation. There is a form of this that we see in envenomation called venom-induced consumption coagulopathy. And it's caused by venom components, which downregulate clotting pathways and may cause vasoconstriction, the formation of microthrombi, and microangiopathic hemolytic anemia, which we can also see on its own as a consequence of venomation. But this all speaks to the importance of doing the coagulation studies. So like a 20-minute whole blood clotting test, perhaps a prothrombin D-dimers, and really just making sure that we're mindful in the medications that we administer to these patients that might be experiencing either clotting or severe hemorrhage and bleeding. Now, in terms of intervening only with antivenom, we have a case here of an individual who's 65-year-old man, no cardiovascular risk factors, had elevated troponins, and then on ECG had a left bundle branch block, which, you know, it's not the greatest quality image here, but after 3 days had completely normal ECG, and the only treatment administered was that antivenom. So this brings us now to inflammation due to venom hypersensitivity. So the authors postulated that based on the elevated troponin and a completely normal ECG, as well as a followed up echo, this likely was a case of myocarditis, transient myocarditis due to venom toxicity and effects on the endothelium as well as the myocardium, and completely resolved with the antivenom, so no other intervention was needed. Finally, I'll discuss the more deadly outcome and the cases where patients typically don't recover, which is ventricular fibrillation. So we had here a case of Ringel's cobra, and this was a 23-year-old male, no underlying health problems, and presented with tachycardia, hypertension, tachypnea, and was transported via ambulance to the hospital, and on transport was given adrenaline, atropine, and defibrillated, and then did not actually make it to the hospital. And what's important to note about this case is the importance of early recognition, and perhaps if we had given an initial bolus of the antivenom, and that might have changed the outcome. Of course, we can't say that, but what was good about this case is that we were then able to look at some of the pathophysiological findings through autopsy. So we saw that on histopathological sections of the left ventricle, that there was marked interstitial vascular dilatation, as well as congestion and some focal subendocardial papillary muscle fibrosis that actually extended fully into the underlying myocardium. And on the left, you can see the formation of a thrombus there in the tissue. And then the right is just subendocardial papillary muscle fibrosis. So this comes back to our venom-induced consumption coagulopathy, where we saw the spread of microthrombi and how this impacted the myocardial tissue. And then there was likely also some direct damage to the cardiac cell membrane, but it was important to see that this venom-induced consumption coagulopathy was then validated also in autopsy results. And then another case on the opposite end, instead of the formation of several thrombi, this is a 27-year-old male who had ventricular fibrillation and was not able to recover secondary to snakebite. And then on autopsy, there were several hemorrhages, including a subendocardial hemorrhage at the left ventricular outflow tract. And then on microscopic examination, had diffuse intramyocardial hemorrhages with extensive interfiber and interfiber-free lying erythrocytes. So this shows the other end of the spectrum and how we really can't predict, even when both patients had ventricular fibrillation, their histopathological findings were very different. And then just briefly to touch on two other concepts that are discussed in the literature and case studies, we do see that many patients present on initial admission of systemic implications of snake envenomation with atrial fibrillation and toxin-induced arrhythmias. These all resolve with that administration of antivenom if they don't progress to something more severe. So if it's not an early sign of, for example, ST elevation or STEMI. And then we also see sometimes, because acute kidney injury can occur due to envenomation, we can see hyperkalemia then resulting in sudden cardiac arrest. So kind of some important points to take away again, in terms of antiplatelet and coagulation therapy, really important to think about the thrombocytopenia and coagulopathy that occurs in these patients, do a coagulation profile, and administer the antivenom in order to reverse that, and then hopefully reduce the amount of medical and surgical management needed for other complications. And then seeing and noting that myocarditis, toxin-induced arrhythmias, and coronary vasospasm can resolve very quickly with the administer of a large bolus of antivenom. And then, of course, the most important note of this presentation is that ECG should really be considered as a vital sign for systemic effects of snake envenomation. It's an incredibly powerful tool. It's available in most resource-limited regions. It's not as expensive as, for example, an echo. And it can tell us so much about the initial signs of cardiovascular involvement of snakebite envenomation and hopefully guide management. So I want to thank you all for listening to me here talk about snakebite envenomation. And after Jeremy's presentation, I think we'll have a question period there as well. Thank you.
Thank you, Chiara. So do you want to, we can ask if, we can have a discussion after, but are there any immediate questions for Chiara directly related to her presentation from anyone?
I do have a question.
Yes, go ahead, Adrian.
So, Chiara, how relevant for the immediate outcome of a person who has been bitten by a snake is the identification of cardiovascular involvement? If we do so, do we change by diagnosing cardiovascular involvement the possible outcome, or is just a pour les galeries thing and the patient is going to die anyway for non-cardiovascular reasons? Thank you. Great presentation.
Thanks, Dr. Baranchuk. No, absolutely. I think that the early identification of cardiovascular involvement is incredibly important. We saw it early in one of the cases with the ventricular tachycardia where the administration of the amiodarone was vital to saving this person's life, as well as identifying STEMI, for example. If a stent needs to be placed, that needs to be identified early, or this patient, of course, is not going to make it. So I think that it's incredibly important to acknowledge that we're not just treating a snake bite, but we're treating a person who has perhaps underlying cardiovascular disease, or treating a person who might have an underlying hypersensitivity to venom. And some of the authors suggested for the case of myocarditis, that if that person had a severe hypersensitivity that did not resolve and also had a hypersensitivity to the antivenom, which is quite common in individuals who already have a venom hypersensitivity, epinephrine could have been vital to management in that case. So I do think that early identification of cardiovascular involvement is definitely life-saving. I think ECG is such an easy way to do that quickly and effectively, the initial screening, and plays a huge role in management as well and seeing progression of outcomes.
Thank you. Any other questions? Yep. I had a question actually, Chiara. With regards to obviously case 2, probably this comes, the situation has merged for case number 2, which is regards to your ST segment elevation. You mentioned at that point, you talked about administration of anticoagulants for these patients that have been bitten. In this situation, how do you think they would have managed this case, or did they give any indication? Clearly, pre-angiogram, you would be administering anticoagulants for your patients as part of the going in for an angiogram. But you say that you have to be cautious. How would this kind of case be managed, that you've got someone bitten by a snake, contraindicated anticoagulant, needs to go in for an angiogram, anticoagulant is indicated?
Yeah, so there actually were a few cases in the literature where that exact thing happened. So they administered a thrombolytic and the patient had severe bleeding, so bleeding from mucous membranes and hemorrhage, and eventually cardiogenic shock, hypoglycemic shock. How this has been managed in the literature that I've seen is that administration of the fresh frozen plasma, as well as platelets and blood in large volumes to help, and then administering, again, that bolus of antivenom with that. It doesn't seem like there are great outcomes for that. It seems like there's a large fatality rate for individuals who have a coagulopathy and then are also given thrombolytics, for example, and start bleeding profusely. So I think that just speaks again to the importance of awareness of this. And I think that also the importance of considering antivenom an important tool for immediate first aid care. So for example, having antivenom available in ambulances, even in places where there isn't necessarily endemic for snake envenomation, as we have more and more people who have access to venomous snakes, and it becomes something to look out for.
Okay, thank you. If there's no questions, we'll go on to the next presenter, and we have Jeremy. Jeremy is a undergraduate medical student from the University of Hong Kong, and he'll be talking about scorpion envenomation and ECGs. Jeremy, please, floor is all yours.
Thank you, Kamala, for your introduction. Could everyone see my screen?
Yep.
Sorry, I will reshare. Okay. So hello, everyone. My name is Jeremy, and thank you for inviting me to speak at today's webinar. Congratulations to Dr. Paul Matusik. Thank you, Kamala and Gary, for co-moderating today, and a warm welcome to everyone. Thank you, Kira, for your insightful presentation. It surely is a tough act to follow, and it has been my joy to work with you. It is my pleasure to speak to you today about ECG and envenomation by scorpions. In my presentation today, I'll briefly start off by talking about the importance of ECG and the management of scorpion envenomation, followed by ECG findings in patients stung by scorpions. I'll go on to dive into the pathophysiological mechanisms behind myocardial injury, arrhythmia, and scorpion envenomation, followed by management by insulin therapy, specifically how it can reverse ECG and metabolic changes in victims. I'll also elaborate further into the therapeutic potential of scorpion venom and anti-cancer therapy, and conclude. Scorpion sting is a major public health problem in many developing countries, especially in tropical, subtropical areas. High prevalence, severity of clinical symptoms, and difficulty of treatment are problems of scorpion sting. It is estimated that an annual number of scorpion stings exceeds 1.2 million, with 2.3 billion people at risk worldwide. The reported case fatality rate due to scorpion sting varies from 3% to 22% among hospitalized children in various studies from India and other countries. And various factors have been suggested as predictors of outcome in cases of scorpion stings. Complications such as myocarditis, congestive cardiac failure, peripheral circulatory failure, acute pulmonary edema have been associated with high morbidity and mortality. In many cases, ECG changes are recorded on admission or several hours later. ECG change marks disease severity, and non-specific ECG changes are characteristic of scorpion myocardiopathy, reported by Giron in 1984. A higher prevalence of abnormal ECG findings is seen in patients with severe symptoms. In one study, the prevalence for patients with mild, moderate, and severe clinical symptoms were 22.2, 35.7, and a whole 100% respectively. ECG change is a prognostic marker associated with high morbidity and mortality. ECG change could have a very wide range in scorpion stings. The earliest recorded findings have been sinus tachycardia. However, the percentage of patients with bradycardia may also be present. In 2013, a cross-sectional study done in Iran was conducted in 43 patients admitted due to scorpion sting, 30% of which had at least one abnormal ECG change, mostly premature ventricular contractions, premature atrial contractions, atrial fibrillation, T-wave, ST segment changes. These heart complications are usually the cause of death, resulting in acute pulmonary edema. The most common ECG finding is PVC, and previous studies have shown the same association, with PVC, LBBB, atrial tachycardia being the most common findings in patients with scorpion bite. In 2019, a single center retrospective study in India was again conducted on 53 patients with scorpion envenomation. The commonest abnormality observed in the study was sinus tachycardia, which occurred in 6 patients, 3 of which had also ST depression. The second commonest seen frequency ECG change was ST elevation with tall T waves. And 1 patient had a complete heart block, and another patient had left anterior hemiblock. In 2014, a study in Turkey tried to determine the ECG abnormalities in 44 patients admitted to an ED with scorpion envenomation. and also to evaluate the relationship between ECG abnormalities and a patient's oxidant-antioxidant system. The PR interval, UQTC, QTD, QPTC, in the patient group were statistically higher than compared to the control group. Mostly sinus tachycardia, T-wave changes, primary atrioventricular block, ST elevation, ventricular extra beats were identified in patients in terms of ECG changes. A significant correlation between TAS, TOS, OSI blood values of patients with and without ECG changes was not established. This case shows that the toxic effects of scorpion venom on the heart are independent of the patient's oxidant-antioxidant system. I will now talk about the relationship between laboratory markers and later clinical markers and ECG variables. Firstly, the laboratory markers are CK, CKMB, CTNI, CTNT, lactate dehydrogenase. In 2019, the same study I mentioned before reported statistical significance in the relationship between serum levels of CKMB patients and ECG manifestations in scorpion bite. Those of ECG changes were found to have higher levels of CK and CKMB. In 2016, a prospective study done in India was conducted on Trojan admitted to scorpion sting to identify the predictors of poor prognosis outcome and ECG changes of victims. They mainly depend on the dose of the venom, the type of scorpion, history of cardiovascular disease, and interestingly, the age of affected child. The differences in the incidence of PCF, myocarditis, CCF were statistically very highly significant compared to control group. And the dose of the venom relative to weight is higher in younger children. Thus, they render them more susceptible to more severe envenomation and greater risk of ECG change. Another possible explanation of this may also be related to delayed presentation due to the inability of younger children to give a correct description of events, and sometimes scorpion stings remain unrecognized, leading to delayed presentation and delayed treatment. Overall, cardiovascular complications following scorpion bite are more common in children below 6 years. And there was no significant difference in the incidence of complications between males and females. Followed by a 2004 study in Mexico conducted on patients between the ages of 5 and 14 years. There was a significant association between the frequency of ECG alterations and age, whereby children from 8 to 9-year-olds are more likely to experience ECG alterations when compared with other tested age groups. The average age of the patients with ECG alterations was 9 years, and 38.5% males presented abnormal ECGs compared to 41% for females, again indicating that there's no evidence of an association between ECG abnormality and scorpion sting and gender. 2003, a study in Argentina, again, reported a similar association where cases in the age group from 0 to 10 years presented a higher frequency of cardiovascular circulatory symptoms compared to those from 11 years or older. However, the frequency of ECG alterations in children does vary in literature between 11% and 64%. These studies on pediatrics have several unique clinical impacts. Firstly, since 8 to 9-year-olds have a higher probability of ECG abnormalities following envenomation. For example, funding can be targeted towards preventive care within this age group. Secondly, these studies may assist medical professionals in assigning clinical priorities to envenomated patients in a triage setting. And while younger age groups may have been assigned clinical priority in the past, these studies indicate that 8 to 9-year-olds specifically may need priority care due to the higher susceptibility to cardiac disturbances. Finally, these studies open a door to further research that investigate the biochemical mechanisms behind the observed age association between age and ECG change following scorpion envenomation. I'll now elaborate on the pathophysiological mechanisms of myocardial injury and scorpion envenomation. Firstly, the scorpion venom is a mixture of neurotoxins, cardiotoxins, and other chemicals. And the venom can cause myocardial damage by several pathogenic mechanisms. Firstly, and most importantly, by autonomic storm, reported in 2014, scorpion envenoming is essentially a syndrome of fuel energy deficits and inability to utilize the existing metabolic substrates by vital organs, which may ultimately result in multi-system organ failure. This is caused by massive release of catecholamines, angiotensin II, increase in glucagon, cortisol, reduction in insulin levels. And these circulating insulin antagonists can cause insulin resistance by different mechanisms. The primary target of scorpion venom is voltage-gated dependent ion channels, thereby causing myocardial injury by channelopathy. Severe scorpion envenoming can cause cardiac cycloma defects displayed by alterations in potassium and sodium levels. Scorpion venom is also able to have direct cardiotoxicity by altering the permeability as well as the electrical properties, and through abnormal electrolyte fluxes and shifts, cause functional damages to the myocardium. It thereby increases myocardial oxygen demand by direct inotropic chronotropic effects on already compromised myocardial blood supply. Second to last, it can cause myocardial injury by myocardial ischemia by coronary spasm. This includes the release of vasoactive inflammatory thrombogenic peptides, which induces vasospasm and thrombosis. Lastly, anaphylactic shock and the release of allergenic proteins, leading to hypotension, vasodilation, and reduced myocardial perfusion. All of these paradigms can cause electrocardiogram abnormalities seen in scorpion stings. In 2014, there was a case of severe scorpion envenomation in an adult patient with the presence of very rapid sustained ventricular tachycardia followed by cardiogenic shock. Scorpion venom can cause cardiac changes that lead to an environment that favors arrhythmia. In this report is the presence of a monomorphic sustained ventricular tachycardia. I've included the ECG of the patient here. Again, the mechanisms are similar to those of myocardial injury, firstly by sympathetic overstimulation by autonomic storm, channelopathy, myocardial ischemia, electric disturbance. Together, these factors could slow down cardiac conduction, contributing to a unidirectional block, which is, of course, a crucial element for the establishment of a reentry circuit and is the mechanism of different types of ventricular tachycardia. All of the above considerations support that life-threatening arrhythmias, such as ventricular tachycardia and VFib, can occur during scorpion envenomation and can cause sudden cardiac death of the victims. 2015, the arrhythmia observed in scorpion venom was substantiated by experimental studies, whereby direct effects of scorpion venom on rat hearts were investigated. Venom perfusion was seen to prominently induce bradycardia with lining QRS complexes and SC depression. In 2020, there was a systematic review that validated the autopsy findings in scorpion sting-related deaths in order to better understand the pathophysiological mechanisms behind the ECG changes. When a sting is fatal, usually the mechanism of death has been cardiotoxicity with terminal pulmonary edema. However, it can also be due to cholinergic excess or the neuromuscular excitation that can provoke respiratory failure. Moving on, insulin therapy has been shown to reverse some of the metabolic and ECG changes observed in patients stung by scorpions. In 1994, it has been shown that insulin reverses the ECG and metabolic changes, as well as the hemodynamic changes in pulmonary edema in both children and adults in scorpion envenomation. Insulin administration in scorpion envenomation syndrome is essentially metabolic support to control the adverse effects triggered by catecholamines and other counter-regulatory hormones. It produces substantial clinical improvement, more glycogenesis in liver, atria, ventricle, and has been shown that a continuous infusion of crystalline insulin supplemented by potassium, and of course, the maintenance of fluids, electrolytes, and acid-base balances has resulted in one study, the complete recovery of 125 out of 130 scorpion sting victims of cardiomyopathy, PCF, and pulmonary edema. In 1999, it's been shown that administration of species-specific scorpion antivenom at different time intervals after venom injection also results in a reversal of ECG changes and a reduction in cardiac enzyme levels, specifically SGLT, SGPT, and LDH. SAV essentially acts to the release of insulin. I'll conclude my presentation by talking about the therapeutic potential of scorpion venom and how it actually relates to its ability to induce ECG changes in victims. The mechanisms by which scorpion envenomation can induce ECG change may be used in anti-cancer therapy. There has been evidence that indicate that the upregulation of voltage-dependent potassium-sodium channels has been linked to cancer hallmarks. Thus, they have become key players as new alternatives to be used as diagnostic, prognostic, and therapeutic targets in cancer. The mechanisms of action of scorpion venom toxins described here relate to ion channel modulating effects, and they give new insights to potential new mechanisms of action in anti-cancer therapy. For example, scorpion venom is able to block potassium channels, and KAAH1, for example, inhibits the migration and adhesion of different cancer cells, whereas KAH2 inhibits the proliferation of gliomas. Other toxins from scorpions, such as iberotoxin, charybdotoxin, are able to inhibit the proliferation and progression in pancreatic endometrial cancer cell lines. Tapemin also exerts a cytotoxic effect on cancer cells. In addition to that, scorpion venom is also able to modulate sodium channels. An example of which is CN2, reduces the proliferation of neuroblastomas by increasing the cells at the sub-G1 and G0, G1 stages, leading to apoptosis. Therefore, scorpion venom might represent a substantial qualitative leap that could open a highway of promising alternatives to be used as adjuvant therapeutic approaches or conventional treatment in anti-cancer therapy. I'd like to conclude my presentation with a few take-home messages. Firstly, ECG change is a common important finding in scorpion envenomation, and a routine serial ECG must always be included in the investigation to early detection of any cardiac manifestation, and if required, cardiac markers and echocardiogram helps in early diagnosis of acute cardiac complications like acute MI. Time delay dictates severity of envenomation. Further study is warranted to survey the serious arrhythmia potential in scorpion envenomation. Predictors such as those from the laboratory and clinically may inform public health policy, clinical priority. And lastly, the channelopathy of scorpion envenomation may advance anti-cancer therapy. Thank you. I'm happy to take any questions.
Any questions, anyone?
I've got a question actually. It's probably more directed to Kira than Jeremy actually. So yeah, thank you both for the excellent talks on the effects of snake and scorpion bites on the cardiovascular system. So it appears that from listening to the two talks that the common theme related to cardiac pathology is inflammation and ischemia. But it seems to me that from Kira's presentation, the underlying mechanism for the arrhythmic changes mostly relate to ischemia and inflammation. Whereas if you look at Jeremy's presentation, there seems to be a lot more studies that have looked at the effects of the venom on the respective ion channels in the cardiac membrane. So I just wondering, Kira, have you seen any literature regarding the snake bites, whether there are any direct electrophysiological effects on the sarcolemma ion channels or on the calcium potassium ATPase that might explain the underlying EP mechanisms?
Yeah, so I was doing some reading on this. It seems that there's most studies, and they do validate that the cardiotoxins associated with snake envenomation do bind to certain ion channels on the cardiac cell membrane and do bind to cardiac cell membrane and can cause damage. I think the issue with snake venom in particular is that there can be, there are hundreds of different compounds that are associated with snake venom, and they all operate quite differently. So I think that heterogeneity makes it difficult for someone to definitively say, okay, I did this mouse study or I did the study on cardiac cell membranes, and now I can say definitively that this is the exact channel or the exact mechanism that is involved in cardiac cell membrane changes or depolarization associated with envenomation. But there's absolutely evidence in the literature that shows us that that snake venom does modify cardiac cell membranes, at least in animal studies. And because we do see so many arrhythmias associated in terms of cardiovascular involvement, that likely happens in humans as well, but it's definitely not as well fleshed out, and there aren't these studies that give us this nice, clear mechanism of how it works like we see with scorpion envenomation.
Thank you for that.
Any other questions? Jeremy, I had well, two interrelated questions. You mentioned channelopathy, and then you talk about hyperkalemia and hyponatremia. Do you actually say effects on electrolytes rather than channelopathy? Because I wasn't clear when you mentioned hyponatremia and then you add channelopathy to hyponatremia. What was the link?
Yes, they're two separate entities.
Okay, so it causes channelopathy and then it also causes hyponatremia, so an electrolyte disturbance, and then a channelopathy being a cardiac channelopathy.
Correct.
Okay. Then when you talk about cardiac channelopathy, what do you mean by it? Do you mean like it has an activation of channels or reducing currents, increasing currents, blocking? What are you using the term channelopathy loosely, or do you have other specific indications of what it does?
From the literature I've read, the venom does block specifically potassium channels.
Okay.
And it modulates sodium channels. However, I'm not sure of the effect on the calcium, magnesium.
Okay.
It is an interesting question. I'll look into further.
Yeah. So then going on to that, using it as a cancer therapy, presumably, and quite, I think the scorpion venom is more of a general blocking agent. So it blocks all types of sodium channels and all types of potassium channels. So how do you envisage to target the ion channels of a cancer cell using scorpion venom, as opposed to targeting the ion and not targeting the ion channels of the heart when you're using it for cancer therapy?
I think the studies that are looking at how scorpion venom may have therapeutic potential in cancer, they're still in very, very early stages.
Okay.
There haven't been any trials or any of kinds whatsoever. So I do think it is quite premature.
Mm-hmm. Okay, that's fine. Thank you. Any other questions from anyone? Yes, yeah. Emanuela, you had.
Good afternoon to everybody. One question I have is that it might be that venom might cause fever, high temperature, and this is also a possible explanation of some of the ECG changes you observed. Do you have a comment on this? As you know, for example, Brugada pattern is increased by high fevers or temperature. So I don't know, I don't have experience with the venom, but, scorpion venom, but from what I read, it could also cause hyperpyrexia.
You're still muted, Jeremy, I think.
Sorry, could you please repeat your question?
Sure. I am saying that I understand that one of the consequences of venom is hyperpyrexia, fever. And this also can cause ECG changes, specifically like Brugada pattern, ST elevation, etc., and arrhythmias. Do you have a comment on this issue?
I did not dive specifically into any literature concerning the pyretic effects of the venom. I'm not sure if Kira, do you have any?
Yeah, I can jump in. I can't speak to scorpion venom. What I will say is that's absolutely a valid point. And yeah, perhaps we could see ECG changes accordingly. I think that's where we administer the early antivenom and see then if the ECG changes resolve. And then depending on the pattern, so let's say you have an ST elevation, you have fever, but then you also have like a retrosternal chest pain or diaphoresis. That's where it's, I think, important to do then maybe like an exploratory angiogram and to make sure that there are no other cardiovascular effects. But from what I've seen in my literature, fever typically resolves fairly quickly with the initial bolus of the antivenom, because you get the anti-inflammatory effects of that as well, because inflammation plays such a role in envenomation. But I think, yeah, it's important to remember that there are confounding variables, absolutely. And not everything we see on ECG is necessarily because of direct cardiovascular involvement. And it's important to treat the patient systemically as well as focus on the possible cardiovascular complications.
Thank you.
Yeah, I've got a question for Jeremy, actually. So it sort of follows on what Cameron was asking, and you'd see the common theme because we actually train in the same laboratory. So we're quite interested in looking at the mechanisms that underlie the ion channel changes. So just quite a broad question. With regard to the atrial and ventricular arrhythmias, are there differences in the mechanisms that that generate these arrhythmias? So have you come across the literature where they talked about any possible trigger activity or re-entry and why they occur?
In the literature I've read, there definitely have been different mechanisms by which arrhythmia occurs following scorpion sting. The foremost prevalent would be by the autonomic storm. It could also be from the direct cardiotoxicity by the channelopathy. It is also observed in coronary spasm related to acute MI and also electrolyte disturbances.
So is that the same case for scorpion, for snake bites as well, Kira? So a combination of delayed conduction and abnormal repolarization being responsible for the arrhythmias?
I mean, again, I'm speaking on very limited literature and case studies here. Yeah, in terms of actual arrhythmias, I think it's a combination of that cell membrane damage. I think it's also a combination of the inflammation, and I think it's like direct cardiotoxicity as well. We also have hyperkalemia confounding possibly due to acute renal failure. I think that it's such a complex presentation, and you have a whole host of toxins that are now impacting different body systems. But yeah, and I think that it's also a case-by-case basis. I think you could have two patients presenting with VFib or AFib associated with snake envenomation and have very different pathophysiologies of how that's occurred depending on the specific venom or the underlying risk factors. So I guess I wish I could give you a more satisfying answer and say specifically AFib is caused this way, VFib is this way, and these are the snakes that do it. But there's even been snakes where there's only one ever case of cardiotoxicity, but it's like very interesting and was dangerous to the patient. And this one snake happened to have developed a certain cardiotoxin in terms of its own venom that's not normally seen in that species. So no satisfying answer there, unfortunately.
No, you guys have answered fantastically, but I think as Camilla can tell you, we've spent these past 20 years categorizing things. So we're trying to look at how much of the arrhythmia is attributed to abnormal conduction, how much is due to abnormal repolarization, how much of it is due to inflammation. I guess it's not that easy to quantify that. Just wondering if Cameron has anything to add.
No, I think, so we often, well, at least me, I try to categorize mechanisms of arrhythmia into three different, and you're right, there could be multiple ways that end up, but you would classify, I would say it's always an activation abnormality, which is largely driven through conduction, sodium channel. And then obviously there's a recovery abnormality, which is your repolarization, which is largely your potassium. And the other one that we call is the calcium mediated, or the excitation, which is the calcium mediated. So I tend to always in my head try to classify an arrhythmic mechanism and find a way or more like an excuse so that I can better understand cardiac arrhythmias, an excuse how I can classify arrhythmias into any one of these three categories. Obviously, some would argue that they can be intermixed, so you could have an activation and a recovery sort of condition occurring, and granted that can happen, but it just helps me get my head around trying to understand why a patient or a case goes into an arrhythmic condition. Now, you're right, potassium, renal will have a consequence, the fever may have a consequence, but the inflammation and the fever, how does it influence the ion channels that cause that electrical sort of remodeling to cause the arrhythmia to occur, is how I then try to pigeonhole this pathophysiology. It helps me. There may be some flaws in that method and people can poke holes in it, but it does help.
Has anyone else got any comments or questions for our speakers? If not, we can also open up the floor as well. So anyone's got any burning comments? Yeah. So if not, just would like to thank the speakers today. So Kira and Jeremy for your preparations. So I know you've put in a lot of time preparing for the slides, so definitely appreciate it. I've personally learned a lot about the cardiovascular effects of these venoms. So this is much appreciated, and it will probably force us to go back to the books and look at the literature a little bit more. And also congratulations to Powell for the award. It's an excellent achievement. You clearly have an excellent track record of publications. So hopefully you'll be able to continue contributing to our society as well. And of course, thanks goes to Tom, who has been our president for the past 3 years. And he's still actively helping with the organizations of the webinars, which is tremendously appreciated by us. And so has Bulent got any comments, or shall I make the announcement for the Facebook page?
Yes, thank you very much. I want to thank you especially for your all efforts for this event. And I want to thank all the speakers and the moderators of the session, and also all participants. We are really looking forward to see you all in the next webinar, which will be in July. I think it will be organized by Professor Volchowicz. We will discuss about the topic later. Have a good day and enjoy the summer. Bye-bye.
Oh, yep. Sorry, just one more thing. Following the approval by council, we are creating a Facebook page for the International Society of Electrocardiology. So this is Bulent and our idea of trying to raise the awareness of what's happening in the society to people who are not necessarily members yet. So if members have any posts they would like to make and you believe is relevant to the whole of society, I think definitely encourage you to send it to me and Bulent, and then we'll post it on the Facebook page. And also we'll be having hopefully posts from Adrian and Gotsil and also Sahib with regard to the Journal of Electrocardiology. So if you have any excellent papers that you've recently accepted and about to publish, you can advertise it on the Facebook page, so you can send it to me. I'll put it up. So yeah. So we're going to be working very closely with the ISE young community as well, as evidenced by the 2 speakers. I think we'll be getting more involved with the raising the awareness of society. I'm getting old, so I can use Facebook, but Gotsil can use Twitter. I'm sure many of you can use Signal or Telegram or some other social media platform, or even Instagram. So maybe if anyone has got any ideas as to how to raise the profile, we'll definitely listen to your comments and act on those as well. Thank you.
Thank you. Bye-bye.
Bye-bye. Congratulations, Pavel.
Thank you very much. Thank you.
Congratulations. See you soon. Ciao.
Thank you. See you soon. Bye.